Good morning or good afternoon to all of you. Welcome to our February Coffee with a Clinician. I'm Tahlia Ruschioni, and I'll be facilitating today's discussion while Education Liaison and Doctor of Physical Therapy Clayton Powers is out of town presenting at the National Physical Therapy Conference on the importance of recognizing post-exertion malaise and adapting therapeutic approaches accordingly. I serve as the education director and the executive director of the Bateman Horne Center, and I'm grateful to be here with you today. Before we begin, I want to express sincere gratitude to the donors whose generosity makes community programs like this possible. Your support allows us to continue expanding access to education and connection for patients and providers alike. I also want to acknowledge the extraordinary interdisciplinary professionals who help strengthen and shape the work that we do. The individuals joining us today as panelists, along with the contributors to our clinical care guide, crash survival guidebook, handouts, lectures, educational videos, they all represent a community of clinicians and lived experience professionals deeply committed to this field. The professionals who contribute to this work bring both clinical expertise and lived experience. Many understand these conditions personally, and that perspective helps shape the way that we teach, the way that we practice, and the way that we care. It helps ensure our materials are informed and keep the patient at the root of everything we do. So thank you all. A little housekeeping. So for this session, Jennifer Bell, Sallie Rediske, and Jaime Booz will discuss Chapter 3 of the Clinical Care Guide, which is focusing on assessing impaired function. And they will answer some of the questions that both participants have submitted, as well as some internal discussion that we feel is important to the topic itself. Jennifer Bell is a family nurse practitioner with a background in family medicine and women's health, and is also a provider at Bateman Horne. Jennifer has two family members with ME/CFS and Long COVID. Sallie Rediske is a medically retired physical therapist and has had ME/CFS since she was 8 years old. Jaime Booz is a speech-language pathologist at the University of Utah Long COVID Clinic and has lived experience with Long COVID ME/CFS. Please paste your questions in the Q&A feature, and we are going to reserve the chat box just for general discussion. Using the Q&A feature is helpful for us as moderators because other attendees can upvote or like that question, which will help us to prioritize which ones that we answer. Jaime, I'm going to start with you. As a speech language pathologist, can you tell us a little bit about your role in helping patients with ME/CFS and Long COVID? And why are speech language pathologists so important to supporting those with ME and Long COVID?
Hey everyone, my name is Jamie. I want to talk a little bit about kind of what speech's role in treatment of ME/CFS is. Speech gets kind of sidelined a little bit, or people aren't aware of what we do. My scope is really broad, so most of the people I'm seeing are coming to me with diagnosis of brain fog. So I'm treating cognition and communication. A lot of what I do is helping people identify their symptoms, figure out how to pace themselves cognitively, handling accommodations and disability. I'm helping them just kind of put words to the experience that they're having. And brain fog's pretty difficult to describe and hard to explain to other people. I feel like that covers it.
Jaime, can you move your mic just a little bit closer to your mouth? You cut out just a little bit for me. I'm not sure if that was for everyone else. Okay, perfect.
Can you hear me better now?
Yeah. Would you mind just
Okay.
kind of going back over that last part? I think it's really important
Sure.
as a speech pathologist for people to understand your role. So if you wouldn't mind, I'm sorry.
Yeah, I work mostly with brain fog. So people come to me saying they have trouble with, memory, comprehension, expression, like, the language functions, and help them and identify their symptoms, understand what's going on when they're experiencing those symptoms and how those interact with other physical symptoms they might be having. And then I also help with putting things together for disability and accommodations for school and work.
Thank you. Before we move on, I'm going to go to Sallie next. But Jamie, you gave a really, really wonderful presentation as a part of our long COVID and post-viral, post-infectious illness echo last year. And we specifically focused on um, trying to inform medical professionals about not only what you do, but how it is so important that their documents um, and their approach to the care with their patients is mindful of both the cognitive impairment piece with these conditions, but also that we're reaching folks wherever they are at with their accommodations and needs. Do you want to just touch on that a little bit? Share what we covered there and why it is so important that healthcare professionals are mindful of the materials that they give when assessing things like impaired function, among other symptoms.
I'm sorry, was that question directed at me? I'm seeing some comments that my
Yes,
mic is still
sorry.
fuzzy. No, that's okay. Am I still difficult to hear?
I can hear you better now.
Okay, okay. That's interesting. I don't normally have trouble with this mic. Um, okay, so yes, in the echo that I did, I talked a lot about how healthcare providers can look at ways that people might be having difficulty with cognition and communication, and then document that. Um, and what was this? I'm sorry. Tell me the second part of your question.
Just the importance of our medical professionals being mindful of the need to have accommodated resources and material, whether that's even audio or setting up their visits in a way that chunk out the assessments so that the cognitive impairment and the post-exertional malaise um, are a consideration for these providers as they assess things like impaired function.
Yeah, I was on the wrong microphone. I think that was probably the issue.
Ah,
So,
you sound
is
great
it better
now.
now?
Yeah.
Okay, fantastic. Okay, I'm like, there's got to be something on my end. Um, yeah, I think the cognition's really hard to pull apart and for people to describe. And so being able to understand, well, we say patients have brain fog, but what does that mean? How does that affect you in different tasks? And every task has some cognitive components. So even if patients are not working, even if they're not doing tasks that we would consider sort of highly cognitive, there are still parts of cognition that impact their ability to do certain things. So simple stuff like being able to do your daily morning routines or nighttime routines, being able to prepare simple meals, making phone calls, those things all require a lot of brain power. And so being able to kind of outline what parts of cognition are affecting that can be really helpful in documentation to be able to outline how systemically everything is impacting their ability to function at work or at school, or whether or not disability is appropriate.
Do all speech language pathologists assess cognitive impairment?
All speech pathologists are qualified to assess cognitive impairment, but we all work in different settings. So some of us do more of that than others. As far as speech therapists that are qualified to work with long COVID and ME/CFS, we're pretty sparse group of professionals, but we're out there. I think more people are learning how to do it, and we're trying to get the word out as far as what needs this patient population has.
While we're on this topic of cognitive impairment, can you define from your lens what cognitive impairment is?
Yeah, so cognitive impairment has, a couple of different domains. I would say the complaints I hear the most people are struggling with attention and concentration, cognitive fatigue, so wearing out really quickly when they're doing something that requires thinking or concentration, short-term memory, kind of word finding, putting thoughts together, keeping your train of thought, which, feels like it's a language function, but language and cognition are really intertwined with each other. And then one of the bigger complaints I hear is executive function. So that's kind of your brain's boss. So it handles things like decision making, planning, organizing, analyzing whether things are going well, if you need to switch gears, kind of handling multiple pieces of information at a time.
And again, since we're on this topic, it just feels it feels like the appropriate time to ask, what are some of those tools that you use to assess and then document for cognitive impairment?
So I use a really broad set of tools. The very first part of figuring out how to manage problems with cognition and communication is just awareness of being able to understand what's going on and when you're having difficulty with it. So we do a lot of, kind of insight oriented therapy, being able to monitor symptoms during a task. What are some good ways to do that without exhausting yourself? Monitoring cognitive and physical exertion at the same time requires a lot of attention and a lot of decision making. So how do we make that part easier? We work on, external and internal memory tools. So things you can do outside of yourself, calendars, lists, notes. What are effective ways to use those tools? Again, to bring down the exertion level when you do. Things you can do inside your own head to help you with memory, communication tools, self-advocacy, building language and description around what it is that's going on so you can talk to family, your employers, coworkers, your doctor about what's causing you difficulty and what things are helpful and not helpful in those settings.
It can be really challenging to identify PEM that occurs after cognitive exertion, and a lot of those cognitive assessment tools. Emotion is another huge stressor, at least I know for myself, when it comes to triggering PEM. So, how do you assess that after you've done the cognitive assessments with your patients? How do you check back in with them to identify if PEM was, or post-exertional malaise was, a consequence of doing some of those cognitive tests?
Right. I think that goes back to that awareness piece. Can I identify which parts were cognitive? So, for example, cooking a meal, the really obvious parts of the physical activity, things like being on your feet, leaning over a stove, dealing with heat exposure. But the cognitive components of that are multitasking, the sensory experience, so sound, sight, smell, the decision-making process, keeping track of things like, did I put this spice in here or not? I don't remember, right? So there's a lot of that part, time management. All of that is highly cognitive, and we really can't pull apart the cognition from the physical in that instance. And so a lot of it comes down to trial and error. If we make this part of the cognitive exertion easier or limit the amount of it you're doing, does that result in PEM on the other side or not? If getting rid of some of the cognitive exertion helps limit the crashing, then we can know that cognitive components were causing some difficulty. Obviously, some tasks are, lean way heavily towards cognition, like, reading, socialization, managing your medical care. All of those things require a lot of cognitive exertion. So kind of knowing upfront what parts of those are hard. Social activity tends to be extremely tiring. So kind of knowing some ways that you can bring down exertion in those areas can tell you if that's affecting PEM.
Thank you. I think, it's one of those things that we just do so subconsciously, thinking and processing, that it can be so hard to recognize how it contributes to the symptom exacerbation. And I think that we sorely underutilize speech language pathologists in this field in a way that can be both therapeutic for the patient, but also very functional in how you and your specialty can help with daily living. So thank you for going into that with us.
Of course.
Sallie, I'm going to turn to you. When we're talking about function and functional impairment outside of the cognitive piece, can you help define for us what therapists or healthcare providers mean when they use that word function or functional impairment?
Yeah, so I'm going to do just a quick little synopsis of function in how it's used in multiple contexts across healthcare, because I learned a long time ago that healthcare providers don't understand it, and patients don't understand it. And it's really important for patients to understand it so that you can be a good advocate to help guide your care it's really unfortunate that we have to be as strong an advocate for ourselves as we need to be, but it's really, this can be an empowering tool to understand these terms. So function just means an activity, the ability to do an activity. And this can be anything from as simple as breathing. Breathing can be actually quite complex for some people, but it can extend all the way to working, socializing, to things like skydiving. So anything like that is a function. Functional impairment that we've been talking about can be a physical activity, or like Jamie's been talking, a cognitive activity, or anything like that. And it has to do with how our symptoms impair or limit our function or our quality of life. So it doesn't necessarily have to be how it affects actually our ability to do work, but it can also affect how our joy is impacted in life. And so that often is minimized in certain healthcare settings and certain questions that we are asked, but joy is really an important part of life, and functional impairment falls under that category. And then the other areas that I want to just quickly mention so that people understand that how these are related is there are functional conditions, and this is separate from function and functional impairment. And functional conditions are disorders that don't have a structural component. So these are issues that when you have a lab test or maybe a image done, they can't find an identifiable, measurable, visible cause for it. And sometimes these issues are just that science is not caught up. So an example would be the stomach ulcers that, back in the 1980s, they found that H. pylori and the NSAID or Aleve erosions that came with the stomach ulcers. That's what that was coming from, not stress. But they used to blame it on stress. So you see how over time that changed. But functional impairment, and functional condition are not, those are three separate things. So I just want you to understand that. And then there's another thing that is very commonly talked about in the ME and long COVID world, and is functional neurological disorder. And that is a functional condition. So that's a very specific one of these conditions. And the real part that's really important to understand about this is that a lot of the people who are diagnosing this are not aware or familiar with ME and long COVID. And so when they do your diagnosis, when somebody makes a diagnosis, they have, a pile of diagnoses, potentially pile, maybe they only have two, but they're considering all these different diagnoses. And if they don't have ME and long COVID in that pot of diagnoses, they're never going to consider it. And so they might just pull out FND. And that's a problem because FND treatment is not the same as ME and long COVID treatment, and they can actually end up harming you. And so understanding that and recognizing that functional condition, functional impairment, and FND are not the same thing. So that's really important. And then the last one is a functional medicine doctor. So this is another one. So functional medicine doctor is a philosophy of medicine. And these doctors purport that they focus on the root cause of a healthcare dysfunction, and they tend to focus on lifestyle changes and nutritional changes as the driver of how they treat. And this can often be, you can often see them use a lot of times now in common language now, they will use the terms integrative healthcare. That's maybe a more common way to use to describe them. But anyway, it's really important that you understand the difference. These are not all related to each other. And so that's my little functional lesson.
No, that's perfect, because I think you highlighted something very important, which is that there are very distinct differences among those. And sometimes, well, not sometimes, a lot of times in medicine, when people are not informed about conditions like ME/CFS and long COVID, it can be really easy to slap on a diagnosis such as FND, and that then can follow that patient in a way that both impedes their ability to get the care that they need. But it also then means that we're not doing a good enough job on the academic side, right, to inform these providers on how best to support these patients. So thank you for taking the time to separate those for us. We're talking a lot about the function of patients and the symptom exacerbation that comes sometimes hours or days after doing an exertional activity, whether that's cognitive, physical, emotional, or orthostatic sensory in nature. From your practice as a physical therapist and also as just a healthcare professional in general, why is it so important that we capture what happens to an individual's function and that symptom exacerbation days after the in-office assessments or those structured evaluations when PEM is most present?
Well, specifically for ME and long COVID, one of the big deals is that until there is a treatment that is effective, so many individuals end up needing to have disability support. That is the first thing. And so providers who are educated on these diseases need to start from the beginning, treating individuals and documenting accurately and effectively in the likelihood that this person may end up having to file for disability. And what happens in many cases is that the person hopes, as we all do, that that day will never come, and the process goes on for a while, and they resist, and everybody's hoping that that doesn't happen. And then the day comes, and you decide it has to happen, and then it's a crisis because there is nothing in the chart that supports what the patient needs. And so disability, Social Security, and private disability companies, by and large, are not looking at the diagnosis. They are looking at what an individual can do. And so that, again, is function. And function is interesting because we all know people who have seemingly a large bucket of symptoms, and they have a low level of dysfunction. And then we know people who seem to have a small bucket of symptoms and they are significantly impaired. And so that is one aspect of capturing people's function, is how it individually affects everybody differently. So that is part of it. The other thing about capturing function is that it needs to be done over time to show either the lack of progress in management or the worsening of symptoms, or in the wonderful opportunity that maybe somebody does get better. The other part of it is to capture the PEM, and that's the part that is the real distinctive part of ME and long COVID, is to show that most of us will be able to elaborate that an emergency situation, we can run out of a house if the house is on fire, but talk to us 2 days later about what's happening. And could we go to work? Could we process our bank account? Could we do our bank account? Could we, go to the grocery store? Those are that has to be documented. And so having providers who understand and can use tools that capture the function in the moment and then later on, and then do it over the long term so that it shows this long history and the severity of the disability, is what's really important.
That was a perfect segue into transitioning to Jennifer Bell, where we talk about some of those tools. So, Sallie, thank you for setting me up. And to your point here, Jennifer, it is so important, and we recognize this a lot at Bateman Horne Center, that it is that after piece that we have to catch that paints the picture of what the impaired function looks like, but also what are those limitations and how do we help patients there. So in our clinical care guide, we listed some of those tools, things like the good day, bad day questionnaire, hours of upright activity, using the fun cap questionnaires. Um, would you mind telling us a little bit about how you use those tools? And before we go into this, I just want to caveat, when we say good day, bad day, what we mean is baseline day and PEM day, because there's never really a great day living with these illnesses, and we recognize that. So just placing that caveat out there. Jenny, how do you use these tools clinically to assess where your patients are at? And then more specifically, how do you use them then to help identify work, school, home accommodations, and how do you use that to help with disability?
Yeah, thank you, Sallie, for setting the stage. That was great. um, so the good day, bad day questionnaire and the hours of upright activity, I think are the ones that I use primarily the most. I haven't really worked with the fun cap that much, but I know it's something that that we're contemplating adding more into our assessment process. But the good day, bad day, hours of upright activity is a subjective uh, metric that patients provide us with information. It provides a guideline on kind of how we want that information organized. The hours of upright activity is basically where we ask patients how often or how long are they upright in a 24-hour period. And by being upright, I mean their legs are down more than 30 degrees down, so they're on the floor, even if they're seated in a recliner, but their legs are down, or they're standing or walking. It doesn't mean they're reclined with their feet up or their legs are tucked underneath them. So it's really getting that idea of the legs being down and that upright stress that's caused by standing or sitting. And so getting an idea of how many hours in a 24-hour period they can do that can be a really helpful metric of understanding how much orthostatic intolerance is affecting their abilities. And then we ask, sort of in combination with that, is the good day, which, as you said, Tahlia, is, it's not like a perfect, pre-illness day. It's the best day you have versus the worst day you have. And we often ask it in the time frame of a month, how many good days in a month and how many bad days in a month. And a lot of times people have a lot of gray days that don't fit into either. So we allow for that. And what we ask in this is ask them on your first of all, how many good days a month do you have? And how many hours of upright activity do you have on those days? And then we ask them, what can you do on those days and what can't you do on those days? And then we go and ask them the same question for the number of bad days a month. Again, how many hours of upright activity on a bad day, and what can you not do on those days? And obviously, it depends on when the patient's answering this questionnaire as to how much energy they can put into answering it. But what I find really interesting is how it's very reality based. I think being a clinician and growing up in or my provider self growing up in sort of the focus of healing patients, making them healthy, it's really required me to step back and become more humble and become more reality based as to what really is happening for patients. And every time I get one of these reports back, I take a deep breath, because it's amazing as to when somebody will often get on a visit with me and say, "Oh, I've been doing better this month or the last 3 months," and then we start maybe talking about what they can and can't do, and it provides a much more real picture of what's going on. And I kind of created an example of a composite of patients that are in my head. of what an answer to a good day, bad day questionnaire might look like. So a patient might report that they have 5 good days a month, and although on those days they can be upright for 4 hours in that 24-hour period. And the majority of ME/CFS patients, based on all of our experience with ME/CFS patients, is usually the hours of upright activity usually isn't much above 7 or 8 hours a day with ME/CFS, whereas with other more chronic fatiguing conditions, that hours of upright activity is higher. 8 hours is good within our patient population. And then they might have an answer like, and in those 4 hours, I can make a simple meal. I can shower and wash my hair. I can vacuum for 15 minutes. I can maybe do a load of laundry, write a simple email, maybe read for 20 minutes, walk outside to the mailbox, converse with my family. And often there's a caveat in there. I can't do all that in one day, but these are the things that I can do. They cannot exercise, cannot go to the store, drive their children to school, read for more than 30 minutes. And then on the bad day, they might answer, they have a HUA, or hours of upright activity, of 1 to 2 hours. And on those days, they can heat up a pre-prepared meal, do simple hygiene such as wash their face, watch a little TV, look at their phone. They cannot go outside, do any meal prep, shower, read or write, leave the house, or have any social interaction beyond the necessary. And so that's a pretty powerful picture of what's going on for somebody's function. And so I find, and if we do this on a periodic basis and create that foundation of that waxing and waning of function, it does start creating a picture of what this person's ability, both cognitively, physically, emotionally, the different types of function that we talked about, they actually have on a day-to-day basis. While this is really powerful, certainly from a clinician standpoint, it's self-reporting by the patient, which is really important. But from a disability standpoint, it's not objective enough. It's not somebody else looking at that patient and giving an idea. So I find what's really important as a clinician, Sallie already mentioned this, that it's critically important that my chart notes don't just say healthy appearing, well-groomed, in a good mood today and move on. I need to be really talking about, are they sitting up or are they lying down? What is their cognition level in the beginning of the visit and what's happening at the end of the visit? Is their word finding declining? Is their ability to keep their eyes open during the visit being affected? Is their posture changing? So they start sitting up, maybe in bed with their feet up, and now they're slumped down on the pillows. Are they having difficulty recalling words and maintaining communication? Those are things that I, as a clinician, have to be. That's what I need to be providing. I need to provide that objective data, and I can do that through telehealth, and I can obviously do that on an in-person basis. So tracking that and making sure that I'm not putting anything in there that is going to create a better picture than it really is, but that I'm putting in there the reality of what's going on. And it's very easy to lean towards being super positive in your chart notes because that's kind of the way we're wired. But it's really important we are reality based, and because it makes all the difference in disability. And I had that experience once in a disability hearing. All that judge wanted me to do was point out in the hundreds of pages of chart notes was, where did I say the patient appeared fatigued and had slow speech? And luckily I had done it, and it was the thing that made the difference, which I was kind of stunned, to be honest with you. It drove that home to me on how important that is. So I think that was a long answer.
No, it was perfect. Because we're coming at this because it isn't just one lens and it isn't just one angle when we're talking about functional assessments and functional capacity that a patient has. And so having that clinical perspective and understanding how you use some of these tools over the course of time to both assess what's happening in that patient's life, but also helping then to identify what are some of those interventions or needs that that patient has to make them have a higher window of capacity, to help lessen the severity and duration of PEM caused by having, an exertional trigger. I mean, it all comes together. And I think that that's, I will say this selfishly, working at Bateman Horne Center, that's why I love working with all the people on this call, because Jaime's speech language pathology and the way that that practice is able to look at the cognitive functioning. Occupational therapy, of course, we know is one of our huge disciplines that we rely on heavily, because they are able to go into the life of that person living in this body and see how they're functioning and see what those supports are. PT, obviously, they play a significant role, as Sallie has already outlined, looking at how the body moves through life and how we can support them. And so all of that comes into this clinical perspective and picture that you then, Jenny, as the ME/CFS expert, has to kind of pull together and figure out what are other driving factors that are limiting their ability to be upright. Is that orthostatic intolerance? Are they having extreme sensory overloads, and that's creating a huge amount of PEM? And so it goes. And then that's where all of our partners here, our allied professionals, come in and help support that patient. So I think that was very important. And just to kind of recap, that all goes into that picture that we try to ensure follows that patient, especially if they're pursuing disability or accommodation needs. So thank you. Jaime, I want to bounce back to you, because I think it's easier conceptually for us to think about function when we think about a body moving through time and space, and the limitations of being able to stand upright, to cook dinner and that sort of thing. It's a little bit easier for us to put our mind around, but the cognitive piece, I feel like we need to spend a little bit more time breaking that down. So when it comes to cognitive dysfunction, how do you choose whether that assessment or even those therapeutic interventions belong with you as a speech language pathologist, or when do you pull in a neurologist?
Yeah, that's a great question. I'm glad that you pulled that one in. There was also a couple of questions about other disorders or illnesses or life changes that might affect cognition. I think those are all really valid things to think about. No one comes to ME/CFS or long COVID without anything else going on with their body. That, those are all normal human experiences. So they're all things that I take into account. As far as whether something falls in my wheelhouse or in neurology's wheelhouse, that's it partly has to do with how we treat things. So neurology is going more from the brain imaging medication side of things. My treatment is really heavily focused on assessing function in cognition and communication, especially, which really, the communication side really is mine. That really doesn't go to a lot of other places. But as far as whether or not I decide to send somebody to neurology, because I do that from time to time, if I think that there's a possibility that something else is going on, like a neurodegenerative process, so dementia, Alzheimer's, MS, Parkinson's, any of those things, and that is really kind of a fine-tooth comb thing that we figure out first before I send someone to neurology, and that involves both my patient and their family. Then I will send them to neuro for that. Hey, I need the doctor to look at this one. If there's a lot of other neuro symptoms that I feel like, hey, this could maybe let's get a holistic picture of some of the other things that are going on besides what I'm treating, then I'll send that to neurology. A lot of times what happens is people get recommended for neuropsych testing, which I think gets confused with neurology. That's not neurology. That's a neuropsychologist that does that. So, and that testing is, may or may not be appropriate for someone based on their needs and based on what symptoms they have. From my standpoint, if I think that we can address the problem with some strategies, some education, some advocacy, coordinating with other professionals, then I prefer to stick with that, right? Like the fewer appointments someone has to go to, the less information they have to be processing, the better in my mind. But neurology is sometimes someone we need to pull into clinical management.
How also do you then differentiate between cognitive processing impairment related to something like ME/CFS and long COVID and that of other conditions like ADHD?
That one's pretty tricky. Most of my patients with ADHD, you come to me with a diagnosis, and if they don't, then we're kind of sussing out, like, is some of this stuff that's been going on before. The problem with someone who hasn't been diagnosed previously to ME/CFS is then when we send them for diagnosis, that's hard to tease apart. But if someone comes to me and they already know that they have ADHD, especially if they're working with someone with medications, whatever that looks like, my role is still really roughly the same. I'm evaluating that patient's function. I'm thinking about strategies that might work for them. Our prognosis or expectations might be a little bit different. I'm often not expecting people to get back to completely pre-illness function. But with ADHD, we're obviously not expecting them to get back to where they were if that was already, they're already having difficulty with things like attention and concentration. I do tend to help people with kind of figuring out whether or not their medications are working for them and that's really purely just because I'm seeing them more frequently than their other providers. And so I can get a little bit clearer picture of, like, I am crashing more often when I'm taking my stimulants, or I have days where I'm not taking them, but then I'm so tired that I can't function, or I'm, so foggy that I can't function. And then I can coordinate with whoever it is that's prescribing their medications and kind of let them know what's going on so that we can, if there's adjustments that need to happen, then they can kind of sort that out. Sometimes strategies are a little bit different. If something didn't work for you before you had ME/CFS, it's probably not going to work for you now. So, that kind of helps me suss out, like, if you've tried this memory strategy or this attention strategy and it hasn't done anything for you when you had ADHD to begin with, it's not going to help now. And so that helps us, like, let's just skip that step and try something else. So it does, as far as approach goes, it's a little bit different. Assessment, like, where are you at? Where could we get to is kind of roughly the same. Approaches are just where things kind of differ.
And you touched on this a little bit, but I want to more specifically ask, because we do get asked this a lot, how do you separate the cognitive impairments with these conditions and that of aging?
Yeah, and that's such a great question. I hear this one a lot, and I also hear a lot of frustrations about it because patients are struggling in a way that feels well out of normal for them, and their family is telling them, or their friends are telling them, oh, I have trouble finding words too, or I forget some things too, or I misplace my keys sometimes. And that's not what they're experiencing. So it feels really dismissive. So, that's something that I provide a lot of support for patients who are kind of dealing with that disconnect between what they see and what their people in their life see. I talk to them a lot about how to describe that to, how do you tell someone this isn't the same as what you're talking about, and give them words to put to it. Again, that brain fog is really difficult to have language for. As far as differentiating between the two, like, how do I tell if something's age related versus ME/CFS? A lot of it is like, well, let's just look at the timeline. If you had COVID and then you suddenly have symptoms, that's not age. Age-related decline, typical age-related decline is more gradual. I look at things like family history can sometimes be a little bit telling. There are symptoms more specific to what I would consider neurodegenerative versus ME/CFS. That's something that really requires, like, an individual assessment. So I'm not going to go into that a whole lot today. That kind of covers, like, as far as the split goes between the two. the other thing to kind of keep in mind is you can't have both things going on. So like that makes it really hard. If someone comes to me and says, well, I was having a little bit of trouble with word finding before, sometimes that might warrant a trip to neurology, like let's just make sure. But overall, if someone's telling me this is an abnormal decline, like this happened all of a sudden, I have other symptoms that are associated, like I'm having cardiac symptoms, I'm having severe fatigue, I'm having PEM related to cognitive exercise or cognitive activity, then that tells me that this is related to ME/CFS and not age related.
Thank you. That was really helpful. Jenny, I want to go back to you from a clinical perspective. So there are many things that can contribute to impaired function from, a disease pathology, a physiologic perspective. What are some of those things that you assess for and acknowledge, and therefore then kind of target when we're talking about trying to improve that window of functional capacity?
Yeah, this is a big area and one that we're constantly learning. So in terms of functional impairment, so we're talking. I'm going to kind of look at physical and cognitive function. From a cognitive impairment standpoint, I think one of the main things that we are confident on that has a huge effect on it is cerebral blood flow. So that means blood getting to the brain. So that's when we talk about orthostatic intolerance, and when you stand up, that blood goes down to your lower extremities, or pools in your abdomen. And if you don't have the ability to really contract those muscles and those blood vessels to get the blood back up, you're going to have a drop in blood flow to the brain. And that has been identified quite clearly in a number of studies. So we know that that's playing a big role in that cognitive impairment, but also plays a big role in that physical impairment, because when your brain doesn't have enough blood going to it, it wants you to lie down. And it's going to make you lie down one way or another, whether you pass out or whether you become so weak you collapse. It's like, this isn't working for me. And so it makes you lie down. So that's one of the most obvious ones of where that affects their hours of upright activity and their ability to be upright and in a way that feels good to them. We also know about neuroinflammation. Neuroinflammation is an area we still have a lot to learn as to what's driving that neuroinflammation, but we know certainly the inflammatory effects of the viral, maybe triggering effects of the viral illness, and that creates sort of an immune dysregulation that creates sort of a persistent inflammatory state. We are, decreased cerebral perfusion may increase neuroinflammation. We also know, and we're diving a lot into this now, and this is way beyond the scope of this conversation today, but what happens if we have inappropriate blood flow in and out of the brain? So venous compression syndromes, and this is a really complex area that there are not many people who are specialists in it, and applying it to ME/CFS is quite complex. But that we know definitely has a big effect on physical and cognitive function. Mast cell activation syndrome is all part of that inflammatory response that can cause a lot of brain fog, a lot of your post-exertional malaise symptoms, everything from severe headaches to GI symptoms to respiratory symptoms, skin symptoms, and a whole host of other ones. So when we are trying to, the primary goal of our care is to improve function. That is the foundation of what we are doing. And so it's not just about treating your orthostatic intolerance or your mast cell or trying to make those diagnoses. It's about what do we need to do to improve your function? What do we need to do to move the needle to a higher quality of life? That is our focus. And we don't have a direct way to fix the core that we know of at this time. We're working on that, but what is driving all of this? We don't have that information, but we know a lot of the things that we can affect, like orthostatic intolerance, like mast cell activation syndrome, and we're getting better at dealing with hypermobility. So again, a highly complex area. But if we can help treat some of those, what we call comorbid conditions like dysautonomia, orthostatic intolerance, mast cell, then we can start moving the needle on that function and quality of life. So we're always kind of looking for that. When I meet with my patients, I'm just looking for places that I can maybe make a slight change, and could that be the thing that helps improve that function. And then the other really, really big piece of this is really helping people understand post-exertional malaise and understand pacing. Because we have learned over many, many years of doing this is that if somebody is not able to pace themselves and keep themselves out of PEM as much as possible, every intervention we try is really not going to have much effect. So really teaching somebody about what are their symptoms, what's that push crash cycle look like, what aspects of that do they have control over, because there are many aspects they don't have control over. So it's really trying to help identify that. And that takes months to years to work with a patient. It takes me a long time to understand it in a patient. It takes a long time for patients to understand it and accept it, because that is a rough one to accept. So that just takes time and patience and grace, basically, to learn about that. And what we have found is patients who are able to really take on that, understanding that post-exertional malaise and what their push crash cycle looks like and what their symptoms, their early symptoms, their mid symptoms, their late symptoms look like, how can they prevent this? When they start finding that stability, a lot of these symptoms start to kind of come down, not fully, but they start to come down and become less impactful.
And I think to your point here, we have functional assessments that we can use and deploy, but it's also so important for providers to be documenting those contributing factors that are leading to the functional impairment, right? And that's where this whole team-based approach comes in, around the multidisciplinary care of the patient, but then also making sure that the provider and the patient are working as a team, right? That it's not being just directed by one or the other. Sallie, I want to go to you real quick because we haven't spoken much about the severely impaired patients, right? So how, for patients who are severe, bed-bound, housebound, how do assessment strategies change? How do providers or can providers adapt some of those assessments for these individuals? Because it can be even more damaging when we're doing some of these assessments for them. We can push them even further into PEM or severity. And so how can we adapt as a field to make sure that we're not missing this severe population of people?
Right. Well, I think the first thing is that the recognition that a lot of the what they call validated or standardized, assessment tests that are out there, the little, quizzes that people take, that are helpful for, mild to moderate people, can be very misleading, because those are created by people in most cases, I think, who don't, they don't see people who are severe and very severe, because they're researchers or clinicians who, are not seeing people who are housebound or homebound. And so even when you read the questions on them, they're not talking about, can you get on a bedpan? Are you, how many infections have you had related to your catheter use over the last year? Things like that. They're talking about things that people with mild and moderate ME and long COVID are coping with. So that's the first thing. And the second thing, a lot of these things that are validated, meaning that they're, that they supposedly catch, what the test is supposed to be looking at, they don't allow for people who are very severe and severe score so badly on these that there's nowhere for them to go at the bottom. It doesn't even show how bad they really are. And so they, they're pretty ineffective. And so then that circles back around to things like the patient activity and symptom logs. And when I say activity, I'm talking about things like what I just said, how did the patient tolerate having a catheter change, and so in those cases, things like documenting, how, what, where, when, who kind of modification was delayed response, what kind of medication changes might have been required to address any kind of flare-up that resulted, and things like documenting that this change, this catheter change, or this bathing had to occur in a dark room, and the thing is even for people that might be able to, either one, they don't have support, or two, they maybe they're able to do some of their own self-documentation. This is an energy drain for the carer or for the individual that might be able to do some of the documentation themselves. And so, like, hearing what Jaime said, I had never even heard that would be a supportive role for the speech language pathologist to help, to coordinate and synthesize, how to document, but, using all kinds of tools, AI, using audio recording devices to make things simpler, anything to get stuff down, and to recognize too that, you don't have to be perfect about this stuff. If you can capture, partial days, an hour, random bits here and there, that can be helpful.
Thank you, Sallie. I think it's always so important that we don't forget how severe this illness can become. And the importance of being able to work with a multidisciplinary team that really understands. And even though access to folks like you all is very sparse and limited, it's part of our mission and why we're doing things like this today, to make sure that more people gain access to that supportive, informed care. So again, I just want to thank you for your time today. We could talk about this forever, I think, and we probably should have another session talking about what function and impairment means for this patient population. But I'm glad that we were able to spend this last hour together to really highlight the importance of this, both from a disability and accommodations standpoint, but also the, honoring the lived experience of having this condition, and in acknowledging the impairment that comes from this, from all aspects of processing and living and functioning with this disease. So thank you again for your time. Thank you for everyone who joined us today. We hope to see you again at our next session on Wednesday, March 11th at 10 a.m. Mountain Time, where we'll be covering the pathophysiology and characteristics of post-exertional malaise. Our team here will send an email with the recording and associated resources at the end of the month to those who have subscribed to our BHC emails. We do hope that you'll complete the brief survey at the end of our session here. You'll see a little screen pop up that you can fill out. That feedback helps ensure that we are creating a forum that is reaching you, and that this is meaningful to you as well. So again, thank you to our panelists here, and thank you all for joining us today. Take care.